If your blood pressure reads 120/80, do you automatically assume that's perfect for you after 60? And I want to challenge that because one number doesn't fit every senior. Too high, and you risk damage to your brain, heart, kidneys, and blood vessels. Too low? That brings dizziness, falls, fainting, and inadequate blood flow. So the real question isn't, what's normal? It's what's safe for you. Age, medications, conditions, and how the reading was taken all matter. Is 120/80 really the target after 60? Or could another range serve you better? Near the end, we'll reveal a blood pressure situation that looks harmless on the monitor, but may put an older adult at real risk. As we age, arteries stiffen, often pushing systolic pressure. When the heart contracts higher than diastolic, it's resting pressure. Older adults commonly see a rising top number. Doctors weigh the whole patient, not one reading. Since white coat and masked hypertension make home monitoring valuable. Subscribe if you're finding this useful, and drop a comment with your age and country, especially if you monitor your blood pressure at home. I'd love to know. Let's break this down with a simple analogy. Think of your arteries like a garden hose, and your heart like the pump pushing water through it. Systolic pressure is the surge of force the moment the pump fires, your heart contracting and pushing blood out. Diastolic is the calmer pressure that remains in the hose while the pump rests between beats. In older adults, systolic often gets special attention, and here's why: a stiffer, less flexible hose surges more with each pump, while the resting pressure between beats may barely change or even drop slightly over the years. That's the pattern behind what doctors call isolated systolic hypertension, a top number that climbs while the bottom stays relatively normal or low. I want to be clear. Though this isn't something you diagnose yourself from a single reading at home or from something you watched in a video. It's a pattern doctors identify over repeated measurements, tracked carefully over time, because one number on one particular day rarely tells the whole story about what's really happening inside your arteries. This is exactly why seniors shouldn't fixate on just the top number or just the bottom one. The relationship between the two matters just as much, sometimes even more than either number alone. That relationship even has its own name: pulse pressure, simply the gap between your systolic and diastolic numbers. A widening gap over time can be worth bringing up with your doctor. But again, this isn't something to self-diagnose from a single home reading taken once. It's a trend worth watching carefully, tracked properly by a professional over weeks and months, not a verdict you reach on your own from one number on one day. Now, here comes the question so many people get completely wrong. Is lower always better? Here's a dangerous misconception I see constantly, that the lowest possible blood pressure is automatically the safest. It isn't, not always, and especially not for some older adults. Aggressively pushing numbers down can trigger real problems, particularly when symptoms come with it: lightheadedness, weakness, blurred vision, dizziness, or fainting, especially the moment you stand up from sitting or lying down. That's called orthostatic hypotension, a postural drop in blood pressure, and it's a genuine senior concern because falls in older adults can lead to fractures, hospitalizations, and a serious loss of independence. I once had a patient whose home monitor showed a great reading, numbers he was genuinely proud of. But he kept getting dizzy every time he stood up from his chair. He assumed lower always meant better and never thought to mention it. The monitor told one story. His body was quietly telling a completely different one. And there's actually one simple measurement technique that can completely change the number you see. Wrong technique can badly skew your numbers. Rest quietly first, sit with back supported, feet flat, arm at heart level, correct cuff size, and stay silent while measuring. Caffeine, exercise, stress, pain, and even a full bladder can all shift your reading. Repeated, recorded measurements paint a far more useful picture than one isolated number, which is exactly why validated home monitors matter. But even measured perfectly, one question remains: what number should make someone over 60 actually call their doctor? Let's map out the actual categories, though keep in mind treatment targets can shift based on your individual circumstances. Normal is generally considered below 120/80. Elevated sits at a systolic of 120 to 129, with diastolic still under 80. Beyond that, Persistent readings in higher ranges are classified as hypertension, sometimes broken down into further stages depending on how high the numbers run. I want to stress, persistent here. A diagnosis shouldn't come from one random reading on one particular day, taken during a stressful morning or a rushed doctor's visit. It takes repeated measurements over time, ideally from multiple visits or consistent home monitoring, to confirm a real, consistent pattern worth acting on. Here's something that surprises a lot of people different. Medical organizations and guidelines sometimes use somewhat different thresholds and treatment goals, which can genuinely feel confusing if you're comparing sources online or hearing slightly different numbers from different doctors. But there's an important distinction worth understanding clearly. What range gets classified as high isn't necessarily the same as at what level a doctor decides treatment should begin, and that's not necessarily the same as the target a doctor aims for. Once treatment has actually started, these three things sound similar on the surface, but they're genuinely different decisions, each weighing your age, other health conditions, current medications, and how your body actually responds to changes over time. Which brings us to the real point. The most important target for you may depend far less on where you started, and far more on what actually happened when your doctor tried to lower your pressure in the first place. Here's the truth I wish more people understood. There's no universally correct blood pressure target for every single person over 60. Doctors weigh overall cardiovascular risk, previous heart disease or stroke, kidney disease, diabetes, frailty, fall risk, how well someone tolerates their medication, whether they experience symptoms of low blood pressure, and their overall functional status and individual circumstances all together at once. Some genuinely healthy older adults may safely tolerate more intensive BP control, while others need a far more individualized, cautious approach. I need to be very clear here. Never change your blood pressure medication just because a video, mine included, mentions a specific number. The safest target is generally the one that reduces long-term cardiovascular risk without causing troubling symptoms or dangerously excessive lowering. Your safest number is not necessarily the lowest number your blood pressure machine happens to display. Blood pressure isn't a fixed number. It naturally rises and falls throughout the day. Many people see a morning surge shortly after waking, which is part of why medication timing can genuinely matter. And some people experience meaningfully different patterns overnight while sleeping, patterns a single office visit will never catch. This is exactly why doctors sometimes use ambulatory blood pressure monitoring, tracking your numbers continuously over 24 hours, because one evening or morning reading simply can't reveal the full picture. I once saw two seniors with nearly identical clinic readings, but their home readings told completely different stories. One ran high throughout the day at home, the other stayed steady. Their treatment plans ended up looking quite different as a result, even though their office numbers matched almost exactly. This is exactly why bringing a home blood pressure log to your appointments matters so much. But here's the real curveball. What if your blood pressure looks normal in the doctor's office, but runs high at home? This is exactly the puzzle white coat and masked hypertension create. White coat hypertension means your pressure spikes in a medical setting from simple anxiety, but runs lower everywhere else. Masked hypertension is the sneaky opposite. Your clinic reading looks perfectly normal, while your everyday, real-world readings run higher. Both patterns matter, and both are exactly why home monitoring can uncover what a brief clinic visit misses entirely. The key is consistency, not checking obsessively every time you feel anxious. Record the date, time, blood pressure, pulse, any symptoms, and medication timing when relevant. That log becomes genuinely useful data for your doctor. Subscribe if this is helping, and drop a comment plus whether your usual reading runs closer to 120/80, 130/80, 140/90, or somewhere else. Now we need to talk about the numbers that should never be ignored. There's a real difference between chronic hypertension and a dangerous acute spike. If you see a very high reading, retake it correctly before assuming the worst. But certain symptoms demand urgent evaluation regardless of the exact number. Chest pain, severe shortness of breath, new weakness or numbness, trouble speaking, severe confusion, sudden vision changes, or a severe, unusual headache. These can signal a stroke or heart attack in progress. Never self-treat or take extra medication without your doctor's explicit instructions. Numbers must always be interpreted alongside symptoms and context. But there's another side to this story when a number looks wonderfully low, yet your body is telling you something is wrong. Just as concerning is the opposite pattern: repeated low readings paired with real symptoms. Dizziness, after standing, fainting, weakness, falls, blurred vision, or worrying confusion, all deserve medical attention, not celebration. Certain medications can contribute to this, but please don't stop anything on your own. That decision belongs with your doctor. Dehydration and other causes are things a clinician can properly evaluate. I once had a patient proudly report her amazing low reading, convinced it meant she was exceptionally healthy. Meanwhile, she'd been having dizzy spells and near falls she never mentioned. A good blood pressure is one your body can safely tolerate, not simply the smallest number possible. So let's return to where we started. Is there a single magic blood pressure number that's safest for every person over 60? No. Many healthy adults aim for something close to normal range, but your target depends on cardiovascular risk, medications, symptoms, frailty, and clinical judgment together. The goal is reducing stroke, heart attack, and kidney damage risk while avoiding excessive lowering and troublesome symptoms. Your action plan: measure correctly, take multiple readings, keep a log, discuss persistent highs or symptomatic lows with your clinician, never change medication alone, and know the emergency signs. 120/80 may look perfect on paper, but perfect on paper isn't automatically perfect for every senior. Subscribe if this helped, and comment your age, country, and usual BP range. The goal after 60 isn't chasing the lowest number, it's finding a level that protects your heart and brain while keeping you steady and safe.